Hi everyone and welcome to our module on the brachial plexus. The brachial plexus is a network of nerves that provides innervations to structures within the upper limb alongside the pectoral girdle. It's an arrangement of nerve fibers running from the spine all the way down towards the axilla and the upper limb. It is formed by the ventral rami of the lower cervical and upper thoracic nerve roots. I'll show you a picture of how that looks like, but being very specific about what particular cervical and thoracic nerve roots give rise to the brachial plexus, we tend to say that the brachial plexus originates from the ventral rami of C5 through to T1 spinal nerves. So T5, C6, C7, and C8 are the lower cervical nerve roots that will give rise to the brachial plexus alongside T1. Aside this, the brachial plexus is said to proceed from the neck towards the axilla and then eventually entering into the arm. So it's not necessarily found directly in the upper limb. It starts from the neck and runs all the way down, passing the axilla to reach the arm. It is responsible for all cutaneous and muscular innervations of the entire upper limb. And this is an image of the brachial plexus alongside the nerves that would eventually supply the upper limb. As you can see, the brachial plexus, although it would begin from the neck, but what we are seeing is the part of the brachial plexus isolated at the axilla, and from this point in the axilla, it will give off branches that will supply the upper limb. Some of these nerves that supply the upper limb are what we call terminal branches. We're talking about them later on along the course of this module. Remember that the brachial plexus originates from the ventral rami of C5 to T1 nerve root. What exactly do we mean by ventral rami? Now, note that whenever we have a spinal nerve originating from the spinal cord, spinal nerves tend to come out of the spinal cord in at two particular points. We have a part of the root of the spinal nerves called the ventral roots. The ventral roots originate from the anterior part of the spinal cord, and then we have a part of the spinal nerves originating from the dorsal part or the posterior part of the spinal cord. This is called dorsal root. One key thing to remember is that the ventral root contains motor fibers. They're involved in the motor aspect of the nervous system, whereas the dorsal root contains only sensory fibers. They're involved in sensory aspect of the central nervous system. Now, these two roots, the dorsal root and the ventral root, will meet together at a point, and after meeting at the point, there would be a mixture of both the sensory fibers coming from the dorsal root and the motor fibers coming from the ventral root, and this mixture would eventually lead to a branching of or forming two new nerve fibers. The nerve fibers that are giving rise to at the end of the division are the anterior rami, what we call ventral rami, and then the posterior rami, what we call dorsal rami. And what you need to remember is that there's a difference between an anterior rami and or ventral rami as compared with the ventral root. Anterior rami contains both a mixture of motor fibers and sensory fibers. As you can see, there are blue and red fibers running within the anterior rami. Same thing with the posterior rami. Posterior rami also contains both sensory fibers and motor fibers found within the single nerve fiber. And this is contrast to what we see in the dorsal root and the ventral root. Dorsal root only contains sensory fibers. As you can see, the dorsal root contains just the blue nerves or blue neurons present in it, while the ventral root contains only motor fibers. Now, it is from the anterior root of ventral rami that from the anterior rami or ventral rami that we have the formation of the brachial plexus. Remember that brachial plexus comes from the anterior rami of C5, C6, C7, C8, and T1. The reason why we call the brachial plexus a plexi is because of the fact that the roots where it originates from, that's the ventral rami of C5 to T1, tends to interconnect with one another, giving rise to multiple components. And from these components, we eventually will get terminal branches that would supply the upper limb. Some of these components include trunk, so the roots will become trunks when they start to intertwine. Then the trunks will later on intertwine to give rise to divisions, and then the division to intertwine to form cords, and then finally from the cord we have the terminal branches, which are the main nerve supply to the upper limb. Let's talk about the various components of the brachial plexus, starting with the roots. The root of the brachial plexus is said to originate from the anterior rami of C5, C6, C7, C8, and T1. That's the lower cervical spinal nerve and the upper thoracic spinal nerves. When they originate from this point, they tend to run within the posterior triangle of the neck. We'll talk about posterior triangle when we get to the module on head and neck. Within the posterior triangle of the neck, the roots of the brachial plexus are covered by skin, the platysmal muscle, and deep fascia, and they are also crossed by some structures. They are crossed by the supraclavicular nerve. They are crossed by the inferior belly of the omohyoid muscle. They are also crossed by external jugular vein and transverse cervical nerve. And as they descend through the neck, they are descending towards the axilla. As they descend through the neck, they tend to be sandwiched between two major muscles. The muscles that tend to sandwich the roots of the brachial plexus includes the scalene anterior and the scalene medius muscle. And this is a very important point to note. Once they emerge from this scalene anterior and scalene medius muscle, once they emerge between these two muscles, the upper part of the root of the brachial plexus usually lies above the top part of the subclavian artery. So they're well related to the subclavian artery. In this image, we can see the various components of the brachial plexus. The ones to note are actually the roots, the 5 roots of the brachial plexus, including the ventral rami of C5, C6, C7, C8, and T1. What you should notice about them is the fact that they are all originating directly from the cervical and thoracic vertebrae. It's from this vertebrae within the neck that they would emerge from and run down into the axilla. The 5 roots of brachial plexus would eventually unite to give rise to 3 trunks. The first 2 roots, C5, C6, would unite to form what we call the upper trunk. The second, the third root rather, that C7 will continue as the middle trunk, so it does not unite or divide with any other of the roots. Then the last 2 roots, the C8 and T1, would unite together to give rise to the lower trunk. So we have 5 roots becoming 3 trunks. The trunks are formed near the lateral border of the scalene muscles, and they tend to descend towards the root of the neck. At the root of the neck, they would eventually give rise to what we call divisions. I will talk about divisions next as the component of the brachial plexus. One extra thing to note about the trunk of the brachial plexus is the fact that unlike the roots, the trunk tends to pass lateral to and lie behind the subclavian artery, and this is contrast to what we have for the root of the brachial plexus. This is the image showing the trunk. You can see how the roots become trunks. We go from 5 roots, C5, C6, C7, C8, and T1, and then we get to 3 trunks. C5 and C6 will unite to form the upper trunk, so this is the upper trunk here. C7 continues without uniting or dividing to form the middle trunk, and then C8, T1 becomes the lower trunk. The divisions of the brachial plexus are gotten from the trunk. Remember that we have 3 trunks of the brachial plexus. Each of these trunks will bifurcate to form 6 divisions. Each of them will give rise to 2 divisions each. That's the anterior and posterior division, and that's how we get to 6 divisions at the end of the day. This division of the trunk to form the divisions of the brachial plexus occurs behind the clavicle. And this is usually the position where we have the divisions occurring at. And from this point, the divisions would enter into the axilla and they will give rise to cords when they recombine. This image shows for us the divisions of the brachial plexus. You can see how 3 trunks become 6 divisions. And what we tend to see is that for the upper trunk will give rise to an anterior and posterior division. The lower trunk will give rise also to anterior and posterior division. And then finally, the middle trunk would also give rise to anterior and posterior division. So we have 3 trunks becoming 6 divisions, 3 anterior, 3 posterior. The cords of the brachial plexus are gotten from the divisions. Each of the divisions would reunite with one another to give rise to 3 cords. So we go from 6 divisions, we go back to 3 cords. Remember, we started with 5 roots. 5 roots became 3 trunks. 3 trunks became 6 divisions, and then 6 divisions would eventually reunite to form 3 cords. 3 cords of the brachial plexus includes the lateral cord, the posterior cord, and the medial cord. And each of these cords are gotten from a reconnection of the divisions of the brachial plexus. The lateral cord, for example, is gotten from a reconnection between the anterior divisions of the upper and the middle trunk. So the upper and middle trunk have the anterior divisions uniting together to give rise to the lateral cord. The medial cord, on the other hand, is formed solely from the anterior division of the lower trunk. So this one is not formed from any reconnection. It's formed directly from the lower trunk and from the anterior division of the lower trunk specifically. The posterior cord is gotten from the union of the posterior divisions of all the trunks. So the upper, middle, and lower trunk, each of their posterior divisions would reunite with one another to give rise to the posterior cord. This formation of lateral cord, posterior cord, and medial cord tend to occur within the axilla, particularly in close proximity to the axillary artery. And this is the reason why we tend to name the cords lateral, posterior, and medial because of their relationship with the axillary artery. So the lateral cords are found lateral to the axillary artery, hence the name. The medial cord is found medial to the axillary artery, hence the name. And then the posterior cord is found behind the axillary artery, hence the name. The last component of the brachial plexus are the terminal branches, and these branches include five major nerves. These are the musculocutaneous nerve, the axillary nerve, the radial nerve, the median nerve, and the ulnar nerve. And these are the nerves that will now give proper supply to the rest of the upper limb. So this image shows for us the cords and the terminal branches that we just talked about. The cords are in green. You can see how the cords are gotten from the divisions. The lateral cord is shown right here. The lateral cord is gotten from the union between the anterior division of the upper trunk. You can see upper trunk and middle trunk, the anterior divisions unite together to give rise to the lateral cord. The medial cord is gotten solely from the continuation of the anterior division of our lower trunk. So you can see lower trunk becomes anterior division here, and anterior division continues as the medial cord. And then finally, the posterior cord, which is down below here, is gotten from the union of all posterior divisions of all trunks. So the posterior division of the upper trunk, posterior division of the middle trunk, and the posterior division of the lower trunk unite together to give rise to a single cord, and that's the posterior cord shown here. The cords will now form what we call terminal branches, and as you can see, we have five major terminal branches. We'll talk about them very soon. They include the musculocutaneous nerve laterally, the axillary nerve, shown in this image, the radial nerve, the median nerve, and the ulnar nerve, which is the most medial. Let's talk about the distributions of the brachial plexus. Now, every single component of the brachial plexus, with exception to the divisions, tend to have branches. So we have branches coming out from the roots of the brachial plexus, branches coming out from the trunk, from the cords, and also terminal branches being branches themselves. The divisions are the only component of the brachial plexus that lack branches. So we'll talk about the branches of each of the different components alongside the particular distribution of these branches and what particular structures that they are supplying in the upper limb. Starting with the branches of the roots, there are three major branches of nerves that originate from the root of the brachial plexus. This includes the dorsal scapular nerve, the long thoracic nerve, and the first intercostal nerve. The dorsal scapular nerve is a nerve that would originate from solely the fifth cervical spinal nerve, that's C5, and this nerve is involved in supplying two major muscles, supplies the rhomboid muscles and the levator scapular muscle. The long thoracic nerve would take its origin from the fifth to seventh nerve roots, and the long thoracic nerve is involved in supplying one major muscle, which is the serratus anterior muscle. Key point to note, whenever there's a damage to the long thoracic nerve, and as a result, the paralysis to the serratus anterior muscle, we tend to see a very high yield deformity that you must remember, and that deformity is called a wing scapula. Then finally, the first intercostal nerve, T1, is gotten from the nerve root T1, and it's involved in supplying the first intercostal space alongside muscles and skins found there. This is something we'll talk about later on the module on thorax. The branches of the trunk are two in number. We have the suprascapular nerve and the nerve to subclavius muscle. These two branches are coming out directly from the upper trunk. Right? No other trunk aside the upper trunk would give off branches. So only the upper trunk of the brachial plexus would give off those two branches. The suprascapular nerve takes its nerve root from C5 to C6 because it is formed solely from the upper trunk. Remember, upper trunk is gotten from the union of C5 and C6 roots of the brachial plexus. Suprascapular nerve is involved in supplying two major muscles, supraspinatus muscle and the infraspinatus muscle. And then the nerve to the subclavius muscle, also coming from the upper trunk, takes its nerve root from C5 and C6 and is involved in supplying just one muscle. And that muscle is the subclavius muscle. Let's talk about branches of the cord, starting with the lateral cord. The lateral cord of the brachial plexus would give off two major branches: lateral pectoral nerve and the lateral root of the median nerve. The lateral pectoral nerve takes its nerve root from C5 down to C7. And you remember that the lateral cord is gotten from a mixture of the anterior divisions of the upper trunk and the middle trunk. Middle trunk is made up from C7, whereas the upper trunk is gotten from C5 and C6. Hence the reason why the branches of the lateral cord would have those nerve roots, C5 down to C7. Lateral pectoral nerve is involved in supplying the pectoralis major muscle alone, and then the lateral root of the median nerve is involved in the formation of the median nerve, which is one of the terminal branches of the brachial plexus. The posterior cord of the brachial plexus would have three major branches to it. This includes the upper subscapular nerve, the thoracodorsal nerve, also called the middle subscapular nerve, and then the lower subscapular nerve. And each of these nerves have different nerve roots alongside structures that they supply. Upper subscapular nerve is gotten purely from C5, and it is involved in supplying the subscapularis muscle. The thoracodorsal nerve or middle subscapular nerve is gotten from the nerve root C5, C6 down to C8, and this particular nerve is involved in innervating a latissimus dorsi muscle. And then finally, the lower subscapular nerve, which is gotten from the nerve root C6, would supply two major muscles, the teres major muscle and then a bit of the subscapularis muscle as well. So subscapularis muscle is going to be supplied by both the upper subscapular nerve and the lower subscapular nerve. Just remember the fact that each of those nerves have a subscapular in their name. So that will remind you about the muscles that they are innervating, particularly subscapularis. Finally, the medial cord of the brachial plexus has its own set of branches. There are four major branches of the medial cord of the brachial plexus. This includes the medial pectoral nerve, the medial brachial cutaneous nerve, the medial antebrachial cutaneous nerve, and then the medial root of the median nerve. The medial pectoral nerve is gotten from the nerve root C8 down to T1. This nerve supplies both the pectoralis major muscle and the pectoralis minor muscle. This is in contrast to the lateral pectoral nerve that only supplies the pectoralis major muscle. The medial brachial cutaneous nerve, whereas would supply skin structures. So medial brachial cutaneous nerve, as the name implies, supplies the front and the medial side of the skin of the arm. The medial antebrachial cutaneous nerve also supplies skin structures, but it is going to be supplying the medial side of the forearm and not the arm. Then finally, the medial root of the median nerve would give origination to the median nerve, which is one of the terminal branches of the upper limb. The medial brachial cutaneous nerve and the medial antebrachial cutaneous nerve are going to originate from C8 down to T1 nerve roots. And this is a picture that captures for us the entire brachial plexus in a nutshell. Just to recap, brachial plexus is gotten from the ventral rami of C5 down to T1. Remember, nerve roots are 5 in number. We have C5, C6, C7, C8, and T1, and they are all color coded in this particular image. Then from the roots, these particular nerves would unite to give rise to three trunks. So C5, C6 gives rise to the upper trunk. C7 becomes the middle trunk without connecting with any other roots. Then C8 and T1 becomes the lower trunk. From the trunks, we go to divisions. Each of the three trunks divide into two divisions each, and we have a total of 6 divisions at the end of the day. And then these 6 divisions would reunite to give rise to cords. So the anterior divisions of the upper trunk and the middle trunk would unite to give rise to the lateral cord. This is what we see here. The medial cord is going to be formed from the continuation of the anterior division of our lower trunk. So this is the lower trunk becoming anterior division, and this is the anterior division becoming the medial cord. And then finally, the posterior cord is gotten from the union of all the posterior divisions of all the trunks. And this is the posterior cord present here. And then from the cords, we have the terminal branches, and there are 5 major terminal branches you should know about. From lateral to medial, they include the musculocutaneous nerve, the axillary nerve, the radial nerve, the median nerve, and the ulnar nerve. Aside these terminal branches, we also have some minor branches that will originate at different points on the brachial plexus. At the root, we have the dorsal scapular nerve and the long thoracic nerve alongside the first intercostal nerve, but not shown in this image. At the trunk, particularly the upper trunk, we have 2 major nerves, and this includes the suprascapular nerve and the subclavius nerve. As you can see, nerve to the subclavius. In the cords, for all the cords tend to give rise to branches. The lateral cord gives rise to the lateral pectoral nerve, and the lateral root of the median nerve. This is the lateral root of the median nerve. Yeah. And the posterior cord gives rise to three major branches. This includes the upper subscapular nerve, the lower subscapular nerve, and then the middle subscapular nerve, also called thoracodorsal nerve, TD for short. Then finally, the medial cord gives rise to its own set of branches. It has a medial pectoral nerve originating from it. We have the median brachial cutaneous nerve and the medial antebrachial cutaneous nerve, all shown here. And then finally, the medial root of the median nerve would also be coming from the medial cord to give rise to the median nerve. And that is just the upper limb brachial plexus in a nutshell, as shown in this particular image. Let's talk about the terminal branches of the brachial plexus. We start with the musculocutaneous nerve. What we need to remember about this nerve is the fact that it's a mixed nerve. It contains both sensory and motor innervations. It tends to originate from the lateral cord. Remember, it is the most lateral amongst the five terminal branches, and it is coming directly from the lateral cord. Lateral cord continues as the musculocutaneous nerve. This nerve tends to run down the arm and forearm. In the arm, it tends to be lateral to the coracobrachialis muscle and found between the biceps and brachialis muscle. This is an image of the musculocutaneous nerve and its course. You can see how it starts from the lateral branch of the or lateral cord of the brachial plexus, and it first runs lateral to the coracobrachialis muscle. This is the coracobrachialis here before it um, enters into the arm, and within the arm it is found sandwiched between the brachialis muscle and the biceps muscle. In this image, you can see that the biceps muscle has been removed for us to see the musculocutaneous nerve, and the muscle that serves as a floor for the musculocutaneous nerve is the brachialis muscle. This is the brachialis muscle down there, and you can see how the musculocutaneous nerve just sits on that brachialis muscle. When the musculocutaneous nerve gets to the elbow region, to the cubital fossa, it tends to become subcutaneous or superficial. It tends to go from being deep, from the deep compartment of the arm to the skin, and it continues as a cutaneous nerve known as the lateral cutaneous nerve, as you can see in this image. So the termination of the musculocutaneous nerve is usually at the elbow region, at the cubital fossa, where it goes from being a deep nerve to a superficial nerve, and the terminal part of the musculocutaneous nerve is regarded as the lateral cutaneous nerve. In terms of what it supplies, the musculocutaneous nerve is involved in supplying all flexor muscles of the arm. So these muscles include the coracobrachialis muscle, the biceps muscle, and the brachialis muscle. All those muscles are flexor muscles of the arm. And then the terminal branch of the musculocutaneous nerve, that's the lateral cutaneous nerve that originates at the elbow, would supply the lateral part of the skin of the forearm and the wrist. And that's the reason why we say musculocutaneous nerve is a mixed nerve. It has both motor and sensory innervation. So this image shows the anterior and posterior compartment of the arm. The anterior compartment muscles are three in number. They include the brachialis muscle, biceps brachii muscle, and the coracobrachialis. And all muscles of the anterior compartment are supplied by the musculocutaneous nerve. And that's just important for you to know. So these are the muscles of the anterior compartment once more. They are three in number, and they are all color coded for you to identify. We have the coracobrachialis in green, then the biceps brachii muscle in brown, and then finally the brachialis muscle in blue. Remember that all these muscles are innervated by the musculocutaneous nerve. They are all flexors of the arm. In terms of the nerve supply of the skin, the musculocutaneous nerve tends to supply the skin over the wrist and the lateral part of the forearm. As you can see, this is the lateral part of the forearm down to the wrist, and this is supplied by that terminal branch of the musculocutaneous nerve that we call the lateral cutaneous nerve. The axillary nerve is the second terminal branch when we are going from lateral to medial. It's also a mixed nerve, meaning it has both sensory and motor supply, and it is gotten from the posterior cord of the brachial plexus. Posterior cord usually splits terminally into two terminal nerves. These are the axillary nerve and the radial nerve. The axillary nerve, once it originates from the posterior cord, would be found largely in the axilla, hence its name. That's why we call it axillary nerve, because it restricts itself towards the axilla. Within the axilla, the axillary nerve first of all passes through a space called the quadrangular space, and within that space, it winds around the surgical neck of the humerus. This is clinically relevant because if there's a fracture to the humerus at the surgical neck, it could be a damage to the axillary nerve, and as a result, symptoms related to axillary nerve palsy would result. Axillary nerve is usually accompanied by a number of arteries, particularly the posterior and anterior circumflex humeral artery. Remember, those arteries also tend to wind around the surgical neck of the humerus. In terms of the distribution of the axillary nerve, axillary nerve tends to supply two major muscles, deltoid muscle and the teres minor muscle. And in terms of the skin innervation, the axillary nerve tends to innervate the lateral skin of the shoulder and the upper arm. This is a picture of the axillary nerve. You can see how it tends to wind around the surgical neck of the humerus once it's originating from the brachial plexus, and it's restricting itself to the axilla, hence the reason why we call it the axillary nerve. The axillary nerve, remember, tends to supply two major muscles, the teres minor muscle and the deltoid muscle. And this picture is just to outline the contour of the deltoid muscle. This contour of the deltoid muscle is the area where the axillary nerve is largely going to be supplying. Skin supply of the axillary nerve is usually at the shoulder region, particularly the lateral part of the shoulder down to the upper lateral part of the arm. So this region, this area is usually called the badge area, because most times if you are wearing a uniform that has a badge, most of the badges will be kept at that shoulder region. So the badge area is the area where we depict as, or we tend to use as an analogy to describe the innervation of the axillary nerve in terms of skin. The radial nerve is the third terminal branch of the brachial plexus. It's the second nerve that would originate from the posterior cord of the brachial plexus. It is also a mixed nerve, meaning it has both sensory and motor innervations. The radial nerve, once it originates from the posterior cord, tends to descend through the posterior part of the upper limb. So it runs through the posterior part of the long head of the and medial head of the triceps, enters into the radial or spiral groove. Remember that the radial or spiral groove is a landmark on the humerus, at the back of the humerus, and that's usually where the radial nerve tends to lodge while passing through the arm. And then it runs all the way down towards the forearm. It's usually accompanied by an artery. The artery that accompanies the radial nerve is called the profunda brachial artery, or the deep brachial artery. And if there's a damage to the humerus at that spiral groove or radial groove, you can have a damage to the radial nerve. Could also have a damage to the profunda brachial artery. If there's a damage to the radial nerve, the condition or deformity that we see is what we call a wrist drop. Whereas if there's a damage to the profunda brachial artery, which accompanies the radial nerve, we see the condition we know as Volkmann's ischemic contraction. So this is a picture of the radial nerve. You can see how it begins from the axilla running to the back of the arm. At the back of the arm, you can see how it turns through that spiral groove or radial groove towards the forearm. Within the forearm, it tends to form branches, and we'll talk about that when we talk about the termination of the radial nerve. So the radial nerve, though it tends to run at the posterior part of the arm, once it gets to the middle of the arm, it turns or moves from posterior to anterior. It first pierces through the intermuscular septum, which separates the anterior compartment of the arm from the posterior compartment of the arm. Once it pierces through the intermuscular septum, it goes from posterior to anterior, and then it continues to descend towards the cubital fossa. At the cubital fossa, the radial nerve would bifurcate into superficial and deep branches. It bifurcates into what they call a superficial radial branch and a posterior interosseous branch. Each of these branches will now go further down the lower forearm, down the upper limb to supply other structures of the upper limb. In terms of the distribution of the radial nerve, the motor distribution of the radial nerve is to all extensor muscles of the arm and forearm down to the hand. So all the muscles of the arm and forearm are going to be supplied by the radial nerve. For the sensory innervation of the radial nerve, it's going to be supplying the posterior part of the skin of the arm, the forearm, the wrist, and the hand. So all the parts of the skin of the posterior part of the upper limb would be supplied by the radial nerve. Remember that the arm is divided into two compartments, anterior and posterior compartments, by an intermuscular septum. The anterior compartment largely supplied by the musculocutaneous nerve. So all the muscles of the anterior compartment, including the biceps muscle, the brachialis muscle, and then the coracobrachialis muscle, are supplied by a musculocutaneous nerve. The posterior compartment muscles, on the other hand, are all supplied by the radial nerve, and the major posterior compartment muscle is the triceps brachii and the anconeus muscle. So this entire area is supplied by the radial nerve. So this is just a picture showing us the posterior part of the forearm. muscles in this particular region, posterior portion of the forearm, are extensor muscles of the forearm, and all the muscles of the forearm in the extensor compartment or posterior compartment are supplied by the radial nerve as well. In terms of innervation to the skin of the upper limb, the radial nerve tends to innervate the posterior part of the arm. As you can see in blue, the entire posterior portion of the arm is supplied by the radial nerve as the skin part. The posterior part of the forearm is also supplied by the radial nerve, as you can see in yellow, and also the posterior part of the wrist down to the hand, particularly the um, the lateral to the lateral 3.5 of the dorsum of the hand alongside the wrist are going to be supplied by the radial nerve. The ulnar nerve is the fourth nerve to note. It's the most medial nerve, so we should ideally be talking about the medial nerve before talking about the ulnar nerve. The ulnar nerve is also a mixed nerve. It contains both sensory fibers and motor fibers, so it's involved in both sensory and motor innervations. It is originating from the medial cord of the brachial plexus. The ulnar nerve, once it originates from the medial cord, will descend down the arm towards the forearm. Within the arm, it is found medial to the coracobrachialis muscle. This is contrast to what we see for the musculocutaneous nerve that is found lateral to the coracobrachialis muscle. As it runs down the arm, the ulnar nerve runs usually anteriorly in the anterior compartment of the arm. At a particular point, it becomes posterior. So this happens by it piercing through the intermuscular septum to become posterior. This is contrast to what we see for the radial nerve, which was initially posterior but became anterior at the elbow joint where it pierces through the intermuscular septum. The ulnar nerve at the junction between the arm and the forearm, that's at the medial epicondyle, tends to be said to wind around the posterior part of the medial epicondyle. And we can easily feel our ulnar nerve just by rubbing on the medial epicondyle, the back of the medial epicondyle. You could easily feel the ulnar nerve at that point. Usually in some individuals, when you rub on that area, they tend to laugh because of the sensitivity of the ulnar nerve at that particular point. So we tend to call that point, we call it the funny bone, just because the ulnar nerve, rubbing on the ulnar nerve at that area will lead to someone laughing. And then the termination of the ulnar nerve, after the ulnar nerve passes through this particular point in the medial epicondyle, it will descend through the forearm towards the wrist. At the wrist, it tends to run superficial to the flexor retinaculum. We'll talk about how it tends to differ with the medial nerve. Medial nerve tends to run deep to the flexor retinaculum. So it runs superficial to the flexor retinaculum, enters into a particular canal called the Guyon's canal, and terminates by bifurcating into a superficial and deep ulnar branch. This is the picture of the ulnar nerve. You can see how the ulnar nerve tends to originate around the axilla, then descend through the medial portion of the arm. It runs largely anteriorly in the anterior compartment of the arm, but at the junction between the arm and the forearm, it turns posteriorly. You can see it pierces through that intermuscular septum to pass behind the medial epicondyle. It finally reemerges at the forearm and then runs on the medial part of the forearm towards the flexor retinaculum. It passes above the flexor retinaculum, as you can see. It's passing superficial to the flexor retinaculum that I'm drawing at this point, and then it runs in a small canal called the Guyon's canal before it terminates by dividing into deep and superficial branches. In terms of the distribution of the ulnar nerve supplies most muscles found at the medial part of the forearm down to the wrist and the hand. So these muscles include the flexor carpi ulnaris muscle, half of the flexor digitorum profundus muscle. These two muscles are found in the forearm, and they are found largely at the medial part of the forearm. So they're going to be supplied by the ulnar nerve. Then the muscles found within the hand include the hypotaenial muscles, the medial two limbrical muscles, the interosseous muscles, and the adductor pollicis muscles. All these are muscles of the hand and fingers, and they are all supplied by the ulnar nerve. Skin supplied to the arm or to the upper limb by the ulnar nerve is done to the skin area of the medial arm, the little finger, and the medial half of the ring finger alongside the medial part of the forearm. So this image is depicting for us the cutaneous innervation of the ulnar nerve in the forearm. The ulnar nerve is said to innervate the medial aspect of the forearm, so it's going to be innervating this particular area all the way down towards the wrist area. So this particular point is innervated by the ulnar nerve, everything in this region. For the innervation of the hand, the ulnar nerve would innervate the palms and the dorsum of the medial part of the palm of the hand alongside the medial 1.5 digit. So if you count from the little finger, there's 1 digit, and then half of the index finger, that or half of the ring finger rather, then this is the 1.5 we're talking about. So the medial 1.5 of the digits alongside the medial part or medial half of the palm and the dorsum supplied by the ulnar nerve. The last terminal branch of the brachial plexus is the median nerve. The median nerve is also a mixed nerve. It takes its origin from 2 points from a medial and lateral roots of the median nerve. Remember that medial root comes as a branch of the of the medial cord, and then the lateral root comes as a branch of the lateral cord. So both of them will meet together to give rise to the median nerve. Once the median nerve originates, it descends on the anterior part of the arm. It tends to accompany the brachial artery as it descends, and at one point it tends to cross from lateral to medial, thereby crossing on top of the brachial artery. It passes deep to the bicipital aponeurosis while in the cubital fossa. And remember, it's one of the components of the cubital fossa. We'll talk about that when talking about the spaces of the upper limb. Once within the cubital fossa, it enters from the cubital fossa into the forearm. Within the forearm, it gives off the anterior interosseous branch of the forearm before it descends down towards the wrist. At the wrist, it tends to run underneath the flexor retinaculum into a particular space we call the carpal tunnel. And within that area, it is found in between the flexor digitorum superficialis muscle and the profundus muscle alongside the flexor pollicis muscle. So as I said, the median nerve tends to pass deep to the flexor retinaculum ligament. This is contrast to what we see in the ulnar nerve that passes superficial to the flexor retinaculum. Once the median nerve passes deep to the flexor retinaculum, it makes its entry into a particular canal called the carpal tunnel. And then from this point, it terminates by dividing into numerous terminal branches that will supply structures within the hand. This is the image showing us the median nerve. You can see how it originates from those two roots, the median root here and the lateral root here will join together to form a single median nerve. And the median nerve will descend through the anterior part of the arm, run into the cubital fossa. At the cubital fossa, it forms one of the branches, one of the components of the cubital fossa, and then eventually it tends to descend into the forearm, anterior portion of the forearm, and at the end of the day, passing deep to the flexor retinaculum. You can see how it runs beneath this structure. This is the flexor retinaculum here. This is contrast to what we have for the ulnar nerve. This is the ulnar nerve, and you can see how the ulnar nerve runs above the flexor retinaculum. Then after it emerges within the hand, it branches into various terminal branches that will supply the structures within the hand. Let's talk about the distribution of the median nerve. The median nerve would supply a lot of muscles of the forearm alongside the hand. So it supplies all flexor muscles of the forearm with the exception of the flexor carpi ulnaris. This is the only muscle that is supplied by the ulnar nerve alongside a portion of the flexor digitorum muscle. Aside these flexors of the forearm, muscles of the hand like the tinea muscles and then the lateral two lumbricals are supplied by the median nerve. Sensory innervation from the median nerve would be to the forearm, to the arm, to the palm of the hand, and then the lateral 3.5 of the fingers. So show you a picture of how each of these innervations tend to look like. So the median nerve supplies cutaneous innervation to the anterior portion of the arm, and then the anterior portion of the forearm. This is the anterior portion of the forearm where the median nerve gives cutaneous innervation to. It would also give innervations to the lateral part of the palms all the way to the lateral 3.5 digits. I'll show you that in a minute. So this is the cutaneous innervation of the median nerve. For the palm, it's innervating the lateral part of the palm, half of the lateral part of the palm, as you can see. For digits, it's going to be innervating the lateral 3.5 digits. So you can see if you count from the thumb, this is the first, second digits, that's the pointer, third digit, the middle finger, and then finally the ring finger being the fourth digit. So we can say half of the middle finger, that's the half, half of the ring finger, that's the half, alongside the first three fingers, giving rise to lateral 3.5 of the digits in which the median nerve will be innervating. Remember that the ulnar nerve will innervate the medial 1.5 of the digits alongside the medial half of the palm. This image shows every single nerve we've talked about, right from the brachial plexus alongside all the terminal branches. The radial nerve, axillary nerve, ulnar nerve, median nerve, and the musculocutaneous nerve are all shown in this image. Let's talk about some clinical significance to the brachial plexus, starting with anatomic variation. Now, it's typically known that the brachial plexus tends to originate from the ventral rami or C5 down to T1. But in few individuals, you could have variations to this origin point for the brachial plexus. The brachial plexus may have origin points starting from C4 all the way to T1, or it ending at T2 instead of T1. So you could have what they call a prefixed anatomic variation, in which we have the brachial plexus originating from the ventral rami of C4 down to T1, and that's like C4 being added. That's why we call it a prefixed brachial plexus. Or we have what we call a post-fixed brachial plexus, in which instead of ending at T1, we are ending at T2. So we'll be going from C5 down to T2. So these are just anatomic variations that we can see in very few individuals, not everyone, but most individuals would have their brachial plexus starting from C5 and ending at T1. Other clinical significance to note would be in the wing scapula that I mentioned initially. I'll show you a picture of how that looks like. Claw and wrist drop. Claw hand and wrist drop are both injuries to some of those terminal branches. Claw hand is the type of deformity we see when there's a damage to the ulnar nerve. Wrist drop is a deformity we see when there's damage to the radial nerve. And we have hip hand and hand of benediction. These are both deformities that tend to occur when there is a damage to the median nerve at different points. And then we'll talk about Erb's palsy and Crohn's palsy, which are palsies or conditions that we see as a result of direct damage to the brachial plexus itself. There is a picture of the winged scapula. You can see how the scapula in this particular individual tends to pop out, forming a wing appearance just at the back of the individual. Remember that wing scapula is as a result of damage to the long thoracic nerve, and as a result of this damage to the long thoracic nerve, this will lead to paralysis of the serratus anterior muscle. It is due to that paralysis of the serratus anterior muscle that we have this deformity called the wing scapula occurring. This is an image of a claw hand. Claw hand, like I said, is typically seen when there's a damage to the ulnar nerve, and this is kind of similar to another deformity we tend to refer to as hand of benediction. I'll show you how that looks like and how we can distinguish it from claw hand. So this is an image of hand of benediction. Hand of benediction is kind of similar to what we see in claw hand, with just a few exceptions. So hand of benediction is due to damage to the median nerve. In hand of benediction, the digits affected are usually the second and third digits, whereas in claw hand, which is due to damage to the ulnar nerve, the digits affected are usually the fourth and fifth digits, fourth and fifth fingers of the hand. This is another median nerve deformity, also called ape hand, and this is usually due to damage to the median nerve around the elbow region. The hand of benediction tends to occur when there's a damage to the median nerve around the wrist. The difference between the ape hand and the hand of benediction is that for the ape hand, there's problems with flexion of the digits alongside absence or inability to oppose the digit. So you can't oppose. Opposition is the movement of the thumb or the contact of the thumb to all other digits. So the ability for you to be able to button your shirt, you need to place your thumb and your other digits together. That's what we call opposition. That particular ability is lost when there's a damage to the median nerve at the elbow region or at the carpal tunnel area. And one of the deformities that we tend to see is what we call ape hand. Aside that opposition being lost, there's also problems with flexion around the planes of the hand. Let's talk about Erb's palsy. This is one of the common brachial plexus palsy that we see. There are two common brachial plexus palsy you should know. One is Erb's, the other one is Crohn's palsy. Erb's palsy tends to be a palsy that occurs as a result of damage to the upper trunk of the brachial plexus. And this damage can occur from multiple injuries. Injuries such as when someone is being thrown from a motor bicycle or from a horse, or when someone lands on their shoulder in a way that widely separates the neck from the shoulder. More commonly, we see it in birth delivery when there's a trauma to a child during birth delivery. Usually, this occurs when a unit is excessively stretched by his neck during delivery. As you can see in this image, you can see the nurse is trying to deliver the child through the head, and as she's pulling the neck, the neck might stretch, and as a result, that can tear the brachial plexus particularly at that upper trunk. Remember that the upper trunk of the brachial plexus is formed by the nerve roots C5 and C6. So when there's a damage to the upper trunk of the brachial plexus, those two nerve roots and branches that tend to emerge from them would be affected. Particular part of the upper trunk of the brachial plexus that is affected during a brachial plexus injury, during Erb's palsy, is what we call the Erb's point. And the Erb's point is where we have six major branches of nerve meeting. We have the C5 and C6 nerve roots meeting, and we have the upper trunk, which is two smaller branches, suprascapular nerve and nerve subclavius, and then we have the anterior and posterior divisions of the brachial plexus. So six nerves, one, two, that's the C5, C6, three, four, suprascapular nerve and nerve to subclavius, and five, six, anterior and posterior divisions of the upper trunk. So this point where each of these nerves meets what we call the Erb's point, and it's the commonest site where um, the injury to Erb's palsy tends to occur. Once this injury occurs, nerves that are further down affected would include, alongside the suprascapular nerve and nerve to subclavius, the lateral pectoral nerve that comes from the lateral cord, the axillary nerve, and then the musculocutaneous nerve are also nerves that will be affected as a result. And once these nerves are affected, the muscles that tend to be supplied by this nerve would also be paralyzed. So, for example, deltoid muscle is affected due to the fact that axillary nerve is going to be affected. Brachialis muscle and biceps brachial muscle would also be affected due to the fact that the musculocutaneous nerve is affected alongside other muscles. Due to the fact that muscles become paralyzed, multiple muscles become paralyzed as a result of Erb's palsy, this leads to deformity of the upper limb. All the regions of the upper limb will be affected and they will lead to a particular form of deformity. Typically, what we tend to see is that at the shoulder tends to be adducted and rotated forward. The arms tend to be medially rotated and extended. The elbows are also extended, but more importantly, the arm and the hand tend to be pronated. So if you look at this particular individual, you can see that there's a pronation of his forearm. All right, there's a pronation of his forearm rather than arm, and then the hand is also pronated, and a bit of the arm tends to be flexed forward. So this particular type of deformity that we see, in which we have shoulder adduction, medial rotation of the arm, extended extension of the elbow, and pronation of the forearm alongside flexion of the arm or the hand, is referred to as waiter's tip or policeman's tip deformity. So I'll show you a live picture of how that looks like, especially in the baby. So this is a child with Erb's palsy, and you could easily identify the waiter's tip deformity in this individual. So aside it being called waiter's tip deformity, we could also call it policeman's tip deformity. It's just like thinking about a waiter or a policeman trying to collect bribe or collect tip from someone, and they have to stretch their hand in such a way so that they not allow their fellow colleagues to see it. And that's what we call it, waiter's tip deformity. The important thing to remember is that in waiter's tip deformity, there's adduction of the shoulder, there's extension and medial rotation of the arm, there's pronation of the forearm, and then there's flexion and pronation of the hand. And that's what we tend to refer to as waiter tip deformity. The second type of palsy we see when there's a damage to the brachial plexus is what we call the Klumpke's palsy. This was named after a particular doctor named Augustus Degeneres Klumpke. And in this particular palsy, compared to what we see for the Erb's palsy, the point of damage tends to be at the lower trunk of the brachial plexus, usually either the lower trunk or the lower two roots of the brachial plexus. Remember that brachial plexus starts from C5 and ends at T1, so nerve roots C8 and T1 can be affected in Klumpke's palsy. Aside that, you could also have a damage of the lower trunk, which is formed by the union of those two roots. Once there's a damage to those areas of the um, of the brachial plexus, uh, nerves that would originate from those areas, nerves that are branches of those particular roots, would eventually be affected. Types of injuries that can lead to a Klumpke's palsy would be injury, for example, when someone is grasping something to break a fall. As you can see in this image, the adult holding a tree is about to fall. So once this adult falls as a result of grasping this tree, if the tree breaks, then that can affect the lower trunk and it can lead to Klumpke's palsy. Another cause of Klumpke's palsy in terms of injury is during delivery as well. But in this case, when the child is being delivered in a way in which the upper limbs are excessively pulled. So that's contrast to what we see for Erb's palsy, in which in that case it's the neck that is excessively stretched. In the case of concave palsy, the arms or the upper limbs tend to be excessively pulled to eventually lead to the damage to the lower two roots or the lower trunk of the brachial plexus. A damage to the lower trunk or the lower two roots of the brachial plexus would affect particularly the intrinsic muscles of the hand and the flexors of the wrist and the finger. This is because of the fact that the ulnar nerve and portions of the median nerve are gotten from those two nerve roots affected. The classic presentation of truncated palsy is what we call a claw hand. And remember that we talked about claw hand when talking about the ulnar nerve. So ulnar nerve damage usually will lead to claw hand. And because the ulnar nerve comes directly from the um, lower two nerve roots of the brachial plexus, C8 and C1, automatically truncated palsy will present similarly to what we have in an ulnar nerve lesion, which is the deformity we call the claw hand. And as you can see, this is what is represented in this particular child. The child most likely had problems during delivery, and as a result, truncated palsy resulted. The reason why we tend to have a claw hand is due to the fact that there's a forearm supination. So there's supination of the forearm and supination of the wrist. This is contrast to what we see for Erb's palsy, in which there's a pronation of the forearm and the hand or the wrist. Aside that, for clunky palsy, for the claw hand, we tend to have hyperextension with flexion at the interphalangeal joints and the metatarsophalangeal joint. So that's the reason why this particular child has this deformity. There's hyperextension and there's flexion at the um, interphalangeal and metacarpophalangeal joints rather. That concludes our model on the brachial plexus.